this video, we will have a very short, simple comparison of GERD and dyspepsia. So GERD is whenever you have any gastric contents that go up to your esophagus and cause any burn-like symptoms. For this, you can do, you can use ranitidine, increase the dose. If your patient doesn't respond to ranitidine or any other H2 blockers, of course, you can go to a proton pump inhibitor like omeprazole. If that doesn't really help, then there's other guidelines, but usually your patient should get better, stop having those GERD-like symptoms. Of course, if your patient has any red flag symptoms like dysphagia, weight loss, if they're older and all of a sudden get GERD, you can consider doing an endoscopy. In most patients, it's not necessary to do H. pylori testing, but if your patient has any risk factors like where they grew up at, where they lived, then you can consider doing H. pylori testing as well. For dyspepsia, so dyspepsia is any upper abdominal pain or discomfort. You can have early satiety, postprandial fullness, pain, or just general discomfort. Most of the causes of dyspepsia are actually like unknown. So functional dyspepsia, once you do all your testing to see what's causing it. But PUD, peptic ulcer disease, is a big cause for dyspepsia, so you want to make sure your patient doesn't have H. pylori. So test your patient for H. pylori antigen in their stool or the urea breath testing to see if they have an infection that you can treat that could potentially make the dyspepsia feel better once it's treated. NSAID-induced dyspepsia, GERD can actually, your patient can have GERD and dyspepsia, and the irritation can cause the dyspepsia, so the irritation from the acid. Any gastric malignancies, of course, and for this, and then also like any pancreatic, anything, really any organ that's, like your gallbladder can cause some dyspepsia. And so for this, since PUD is a major cause for dyspepsia, you can just start your patient on a PPI, see if they get better. Of course, if they have any red flag symptoms, older, weight loss, any blood in their stool, then you can jump straight to an endoscopy. In patients less than 60, just test them for H. pylori, but if they have those red flags, consider endoscopy. And remember, PPIs are more potent than ranitidine, and even if you use ranitidine for GERD, it'll only be good for a short time, because with prolonged use, ranitidine stops being as effective, and PPIs aren't good to use for like long term because of all the adverse effects we're finding out. And then, yeah, that's it. Thank you so much.